Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Inc.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape Education of any specific product or manufacturer.
This program is presented by Medscape Education Global.
Hello, I'm Mary Ranella, Professor of Medicine at the University of Chicago in Chicago, Illinois, and I'd like to welcome you to this program entitled Diagnosing and Managing Obesity-Related Liver Disease, a Multidisciplinary Masterclass. Joining us today are Dr. Bob Kushner, Professor Emeritus at Northwestern University in the Departments of Medicine and Medical Education in the Feinberg School of Medicine in Chicago, Illinois as well, and Dr. Dimitris Papamargaritis, Associate Professor and Honorary Consultant in Diabetes and Endocrinology at the University of Leicester and University Hospitals of Northamptonshire in the UK. So I'd like to get us started with this important topic, recognizing which patients of yours might be at risk to develop obesity-related liver disease. And I'm going to briefly introduce a patient case just to give some clinical context to what we're going to be talking about today. So our case is going to be that of a 68-year-old male. He's got a BMI of 38. He's got diabetes, which he's had for about 15 years, hypertension for 10 years, sleep apnea for 5 years, and he's currently on metformin, glipizide, lisinopril, amlodipine, and atorvastatin. Bob, this is probably the kind of patient you see in your clinic every day. Before we get into detail around diagnosing liver disease, could you tell us a little bit about the burden of MASLD and NASH in this group of people and how are liver disease and obesity related to metabolic dysfunction?
Yeah, thanks, Mary. This is a very common patient that we see. It's someone with moderate obesity with a BMI of 38. And many of the cardiometabolic complications we see that's related to obesity, such as diabetes, hypertension, and sleep apnea. So type 2 diabetes and obesity, particularly abdominal obesity, are commonly seen as the two most common metabolic diseases and the strongest impact on the development of MASLD and MASH. The estimated prevalence is about 70% in this population. Prevalence does vary across the world due to different ethnicities and racial differences, also including social determinants of health and genetics. Now, I want to mention one thing in particular. The prevalence of steatohepatitis in the Hispanic population with or without diabetes is the highest due to genetic polymorphisms. Regarding the etiology, metabolically, the stage of MASLD is set by increased visceral adipose tissue that drains directly into the liver via the portal vein. Also, we have adipose tissue insulin resistance that promotes unrestrained lipolysis during the postprandial period. And this all leads to sustained fatty acid flux to the liver that drives beta oxidation and de novo lipogenesis. On the background of this is systemic inflammation that exacerbates hepatic inflammation and fibrosis, driving MASLD progression. This is all part of this ectopic fat problem that we see with obesity that not only occurs in the liver, but also the muscle, the liver, as we said, the pancreas, and the heart. So putting this all together, insulin resistance and free fatty acids and elevated glucose drive cell stress or apoptosis, increase inflammation and fibrogenic remodeling, leading to cirrhosis, chronic kidney disease, heart failure, preserved ejection fraction, islet cell loss, and other metabolic problems.
Great. So Thanks very much, Bob. This is actually, of course, a very complex problem, but something that we really see regularly in primary care and other, initial settings such as endocrinology. And Demetrius, why don't you follow with a few comments? I mean, knowing that MASLD and NASH are really prevalent in people with obesity, what risk factors do we need to be on the lookout for? And are there particular red flags that you want to look at and you want people to be more aware of, particularly as it relates to the patient that we're discussing today?
Thank you, Mary, for this question. I mean, looking at the patient that we have discussed earlier on, this is a gentleman that is having type 2 diabetes. On its own, this is a key criteria for screening for MAS and MASLD. He is also having obesity and he is having a history of hypertension. So people that they having obesity plus at least one additional metabolic risk factor needs to be screened for MASLD and MAS. This risk factor could be prediabetes, could be triglycerides more than 1.7 millimole per liter, could be low HDL cholesterol less than 1 in men or less than 1.3 in women, or being in lipid lowering therapies. He's having hypertension. This is another one risk factor. Blood pressure more than 130 over 85, and or receiving treatment for hypertension. On top of this, we need to be careful and think about people that they have first degree relatives of patients with cirrhosis due to, or of a patient with cirrhosis due to MASLD mass. And also, as Bob mentioned earlier on, ethnicity is an important factor. People of Latino or South Asian origin, they have higher risk of developing MASLD, as well as people with PCOS is another one risk factor. So overall, I would say people with type 2 diabetes, obesity with at least one additional metabolic risk factor, or people with first degree relative of a patient with cirrhosis due to MASLD mass needs to be screened. And also, we need to think about people with persistently elevated liver enzymes.
Yeah, these are really good points, and I think it's important to emphasize for primary care that these high risk groups really are quite high risk. So just as an example, if you have a first degree relative with cirrhosis from this, you got about a 20-fold higher risk than the general population of having advanced fibrosis. So it's important to look for these patients and to screen them, of course, because you can intervene. So. Okay, so now, when might you suspect that something might be happening in the liver of our patients? So, what kind of non-invasive tests might we be able to use to better understand the health of this person's liver? So, I'm going to go through some non-invasive tests that we use in the clinic, and just kind of break it down so that you're aware of what is on the menu, essentially, in order to do this. So, from looking at serologic tests, there are simple scores that basically just use uh, normal labs that you might order in the clinic. The most notable would be FIB4 index, which is based on ALT, AST, platelet count, and the patient's age. The others that are listed on the slide are, I think, mostly for historical context because their performance is not as good. And I think if we keep things simple and focus on FIB4, that's really what we need to remember here today. Additionally, we have proprietary tests. And I would say the way they're listed on the slide, they're in the order that you should be considering using them. The ELF test, which I'm going to get to, is a proprietary test, and it basically is an aggregate test of fibrogenic markers, which I'll go through in a second. Next would be imaging-based liver stiffness assessment, which the most common, at least in the clinic, would be a VCTE or vibration controlled transient elastography, otherwise known as FibroScan. That would be the most common point of care test, which we use in hepatology clinics. And more endocrinology clinics are acquiring these machines, some primary care. But this is a way, as you'll see in the next couple of slides, how you might do that initial risk stratification. Other potential options are ARFE, which is an ultrasound based test that's available in many hospitals. Shear wave elastography is another technique that can be used as well. Velicure is another point of care test, as is hepatoscope. And then MR elastography, which is the most sensitive and accurate of these modalities is important, usually as a secondary or tertiary line test. So coming back a little bit to the FIB-4, this is the most widely used. It's based on routine laboratory tests, as I just mentioned. And the cutoffs to remember are really 1.3. So less than 1.3 is going to really be associated with a low risk of fibrosis, with some caveats attached to that. FIB-4 of greater than 2.67 is associated with a high risk for development of fibrosis, and we'll go into that in detail. And then there's the intermediate zone, where about a third of patients are going to sit, and those are the patients that really do require secondary testing in order to decide who needs to be referred and who doesn't. So some of the limitations of the FIB-4 are unfortunately in the populations that are at highest risk. And this may be counterintuitive, but the reason for this is that it's not so much that diabetes itself does anything to make the tests less accurate, but it is a population that has a high risk of advanced fibrosis, as Bob mentioned earlier. So this test was developed in a population of low prevalence of advanced fibrosis. So it's perfect for a general practice setting, for the primary care setting, for example. The problem is, as you reach a population that is a higher risk of advanced fibrosis, like diabetes, you have more of actually, for diabetes, you have a potential for false negative more than anything. Then when you look at other factors that influence the test, if you're older, of course, since that's used to calculate the test, that's an important variable that will overestimate fibrosis. And so for people over 65, you need to use a cutoff of 2 instead of 1.3. Alcohol intake, it's not that it falsely elevates it so much as that it itself increases the pressure in the liver. And so if you're acutely drinking alcohol, that's going to cause swelling in the liver. That's going to impact the stiffness of the liver. And it's also going to impact the FIB-4 because the AST to ALT ratio is going to change. And then the low platelet count, of course, it's not a false positive so much as if your platelet count is low in the correct context, that would suggest portal hypertension, which is typically caused by significant fibrosis. So moving on to what would be an important second line test or second step in the risk stratification process would be VCTE. And as I mentioned earlier, this is a modality that we have in most of our liver clinics. It's almost like a liver vital sign at this point. So what this does is it's a machine that measures the shear wave that's generated as a liver stiffness measurement. And this correlates with fibrosis. So as you might imagine, things that are softer propagate waves more slowly. And so if the liver stiffness is not elevated, that would be more consistent with a normal or healthy liver. If the propagation of the wave is very fast and very acute, as you can see in the bottom, this would be consistent with a stiff liver. Or a fibrotic liver can also be stiff for other reasons like heart failure, but generally speaking, in the right context, in a fasted patient, this would be consistent with fibrosis. So, as far as other information that we might glean from a BCTE, we can assess fat content as well, and that is derived or expressed as the CAP score, the controlled attenuation parameter, which generally, when it's over 280 or so, is consistent with significant hepatic steatosis. So, putting it together, the numbers that we most care about are really the liver stiffness test, because that's really going to tell us about fibrosis, which is what correlates with long-term adverse outcomes, and then the CAP score, which I think is more just helpful from a diagnostic perspective to underscore or outline etiology of disease. But it's really the liver stiffness that matters, and the thresholds we're going to go through in the next couple of slides. So the ELF test is another test that we use as secondary risk stratification. And as I mentioned earlier, it's a proprietary blood test. It's approved for, it's not approved for fibrosis confirmation so much as is prognostication. So this test was approved by the FDA to prognosticate who, in the context of a lot of fibrosis, is likely to progress to cirrhosis. And in those who have cirrhosis, who is likely to do poorly. And those cutoffs are 9.8 for progression to cirrhosis and 11.3 for a development of liver-related outcomes. So it measures three elements that are involved in the fibrogenic process: P3NP, hyaluronic acid, and TIMP1. And as I mentioned before, an ELF greater than 9.8 is where somebody is likely to have advanced fibrosis, and those patients most certainly should be referred. This test is a bit less susceptible to false positives and false negatives than FIB4, although important to note that it is also impacted by age and a high inflammatory state. So it's not perfect, but it's actually quite good. It performs probably a bit better in diabetes, but remember, it should ideally be used in somebody who you're suspecting has advanced fibrosis for the performance to be accurate. So moving on to MRI, which is a really important modality. We typically use it in either you can use it as a secondary risk stratification tool if you do not have access to the other modalities. It's more expensive. You can actually order an MRI PDFF and MR elastography together as an individual entity, so you don't have to order a full MRI for this. I think the things to take home about MRI PDFF are that it is the most sensitive way to detect liver fat and to quantify liver fat content. It's the most accurate way to do this. It can detect as low as 5% liver fat, which is the threshold of normality. So if you're looking for something that's going to give you an accurate assessment of liver fat quantification, or you want to see perhaps response to therapy, this would be a good modality for that. MR elastography is the most specific of the liver stiffness assessments. And we use that to, again, diagnose advanced fibrosis and cirrhosis. The thresholds you can see here and are going to be emphasized again when we go through the algorithm. But important to note that the kilopascal assessment on MR elastography is completely different than it is for VCTE. So a threshold of 3.64 is going to give you a high likelihood of having advanced fibrosis, meaning stage 3 or higher. An MRI liver stiffness of 5 is going to be indicative of cirrhosis most of the time, and a liver stiffness of 7 or so is going to be predictive of adverse liver-related outcomes. So now, after you recognize these at-risk patients, what do you do next with them? And so, just up to the upper left, I sort of, in the last several slides, walked you through what we do as far as initially, Demetrius noted the people that you should be looking for liver stiffness or who are at risk for liver stiffness elevation. Those patients then get a FIB4, which is if it's less than 1.3, they basically can be followed in primary care and followed every 1 to 2 years. If you have a FIB4 that's in this indeterminate range, then that would call for supplementary or secondary risk stratification. And those are through either VCTE, liver, or ELF, which can be used. Again, this is not the exact context in which this was created, but we do recommend it because it's a blood test that can be sent off in primary care. And then using that, you then determine whether the patient's more likely to have advanced fibrosis or not and would merit referral. Usually, the um, additional tests that we use in tertiary care are going to be the MR-based methods, MRI, MR elastography, as well as something called MRI corrected T1, which will measure also inflammatory and fibrotic changes in the liver. We use these to then decide who requires a liver biopsy. We don't biopsy people as much as we used to anymore, but we do that if the non-invasive tests are concord or not concordant. So if they're discordant, we would do that. Or if we're suspecting another liver disease, such as autoimmune hepatitis, which is often a consideration because anti-nuclear antibody, which is one of the first screening tools we use for this, are present in about 30% of people with MASLD and MASH. So those would be the reasons that you would potentially consider doing a liver biopsy. So, as I just went through for the AASLD guidance, there have been numerous other guidances from other societies that reiterate the same point, importantly, because we're trying to give the same message across the board so that we're able to guide our primary care doctors and not confuse them. So, this is an example from the EASL, EASD, EASO. So, these are European associations for liver disease, diabetes, and obesity. These are the guidelines for the use of non invasive risk stratification in this context. And as you can see, they're very similar to what we did with the ASLD, uses high risk populations, then applies the FIB4. And then based on the FIB-4, then further risk stratifies patients. So again, very similar. And again, same message across multiple associations. I think it's important to not confuse people and to get the right patients screened and sent to tertiary care. Okay, so we're going to move on to Professor Papa Margaritas, who's going to continue to walk us through this case.
Thank you very much, Mary. So we have this gentleman that we have some blood tests. His HbA1c is 9.2%. He has elevated liver enzymes, creatinine slightly elevated, little low platelets. His FIB-4 score is 3.5. An ultrasound demonstrated hepatic steatosis with mild splenomegaly. So a number of alerts there performing the FIB-4 score for this patient. And we progress as the FIB-4 is more than 2.67, considering high risk for fibrosis, to doing second line investigation. So he had a FibroScan, which demonstrate 25 kPas, and he went also for an MR elastography demonstrating 5.5. Both of them, I think that they are significantly above the threshold of what we consider for advanced fibrosis. FibroScan is definitely more than 8 and more than 12. And the MRE scan, we said that the cutoff for advanced fibrosis is 3.64. So I think that this is an element that definitely will need a referral to the hepatology for further assessment. Do you think, Bob, you agree with this?
It's a very high-risk patient that's going to need further follow-up, and particularly if you're a primary care clinician, referral to a hepatologist.
So I would add to what Bob just said that these thresholds are there are a couple of major red flags in this patient. So the MRE greater than 5 is pretty consistent with cirrhosis, as is a liver stiffness of more than 25. But it's not only consistent with cirrhosis, it's consistent with what we call clinically significant portal hypertension, and that goes along with the low platelet. So this person is not just at risk for having cirrhosis. He probably has cirrhosis, and his risk for adverse liver related outcomes is actually very high. So this is a very high risk patient.
Yeah, I think that we are fully agree on this.
So, Bob, Demetris, as a hepatologist, I really see a lot of patients that already arrive to me with signs of advanced disease. So, I think one of the most important things that we can do is try to help people identify patients before they actually get to the stage of the patient that we're discussing today. This patient already has cirrhosis, but I could say that you could actually see this exact patient with pretty normal liver tests, and you might miss the fact that he has advanced fibrosis. For example, that his platelet count is slightly low. That's a very common scenario. So, how do you both describe the role of other specialties, and particularly in primary care, in helping patients along this journey with metabolic liver disease, and how we might best identify people earlier in their disease stage where we can intervene?
So, Mary, as we already said, primary care is very attuned to individuals presenting with obesity and obesity-related complications, particularly the cardiometabolic complications. And they already work up patients, I think, for development diabetes and cardiovascular disease and so forth. I think it's important to note that the number one cause of death in these patients that come in with MASLD or MASH is really cardiovascular disease. And I think they're already thinking that. But what's new in primary care arena is thinking liver. So we have to add that. I think having a FIB-4 score embedded in the natural flow of care, including in the medical electronic medical record, would help a lot. And then you have the low risk, high risk, and intermediate risk. And that workup, I think you did beautifully, is outlining it for it. Now, depending upon the non-invasive tests, you're going to refer to a hepatologist, and clearly we would refer early to this patient. But because of the advances in obesity, we have a lot of interventions available beyond screening that can actually begin in primary care. One is weight loss. And we've always talked about the foundation of healthy diet, physical activity. We now have also effective pharmacotherapeutic agents. We also know more about treat the target. So we talk about a percent body weight loss. I think primary care is starting to learn that patients at higher risk would benefit from more aggressive weight loss. Now you're talking about beyond 5% weight loss, even 7.5 or 10% weight loss. And it was hard to do that with lifestyle alone before. I also want to mention the importance of a multidisciplinary team. We talked about hepatologists already, but when you're talking about a patient at high risk, you want to think about registered dietitian, a exercise specialist, um, nurse practitioners, health psychologists, and so forth. So you don't have to shoulder this all by yourself as a primary care health professional, but use that interdisciplinary team, which that of course includes the hepatologist.
I fully agree with you, Bob, on this. It's always a multidisciplinary approach. The key thing that we need to highlight, and I think you mentioned this exactly, is these people will die, the key cause for mortality will be cardiovascular disease. So we need to address cardiometabolic risk factors for them, ensure that they are following a healthy and good quality diet, stop smoking, discourage alcohol intake, and support through multidisciplinary care to do lifestyle changes on top of supporting them where available with incretin-based therapies. In some cases, we can even consider bariatric surgery that also has evidence in some of these cases that help these people to achieve significant amount of weight loss and improve progression of mass, especially to cirrhosis. It matters, I think, significantly in what stage of their liver fibrosis they are. I think that the earlier in stage of fibrosis 2 and 3 that we are able to treat them aggressively, the more is the possibility that we prevent the deterioration of the disease and the progression of the liver disease. So all these things needs to be taken into account as part of the multidisciplinary care and approach.
All right. So thank you to Bob and Demetrius for really walking us through this important topic, and particularly important because it's coming from the perspective, your perspective, which is probably the most important at this point in the disease, which is that of obesity medicine, endocrinology, and primary care. So we walk through how to identify a patient who might be at risk, what tools we might use to identify and risk stratify these patients, and which patients should potentially be referred. And specifically, the patient we talked about is somebody who was very high risk for adverse liver related outcomes, and really important to get those patients over for tertiary care so that they can get screened for liver cancer and treated with available therapies if that's relevant for their disease state. So, and thank you very much to the audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.